Thank you very much. Good morning. Hi, how are you? It's an honor to be here, to be the opener of this session. It's a very kind of big title, Challenging the Fluid Challenge. I mean, it's a very provocative title we have got here. Why it is provocative? Because fluid boluses are the pillars of a management of any patient, pre-hospital, ED, ICU, ward, theaters. If you look at all the studies which have been done in the last 10 years in this area, either they looked into what protocol to use or compare the different kind of fluid boluses. This slide I borrowed from Professor Burston. I really like this slide because it kind of put into perspective what we are doing to our patients. Why do we give fluid bolus? Is the question we were asking basically. We give it either the way it was designed originally, like in cholera epidemic, to restore fluid deficit, or probably in the more useful in the modern world, to improve physiology. We give it to improve mean arterial pressure, decrease heart rate, or we have some targets in our head. For the last 10 years, there has been more and more evidence of the adverse effects of fluid bolus. So I'm not going to bore you with these things, but imagine a drug which is tested now and shows a mortality difference, what was showed in Feast. Will it ever get approved to be used in clinical use in the modern world? That was the mortality difference in the Feast drug. I mean, with this is a pretty busy slide, but I want to make 2 points here. The early goal-guided therapy had basically physiological targets. It had a CVP target, it had a MAP target, it had a venous gas saturation target. Even they had the same target, and probably process and arise had the same severity of illness, comparable patients, they gave different amount of fluids. They had the same protocol to follow. Most of the research has been done in the first 6 hours. But the fluid boluses are actually common throughout this day. Look at the amount of fluid these patients got after the first 6 hours of resuscitation. The 2 points I'm trying to make is, it's common. Even if I give you same targets, 2 people will take it differently. Hence, the topic of my talk today. What are the indications? And what are the efficacies? And I'm just talking about the physiological effects of these fluid boluses, like a drug. And we interrogated 2 groups of patients. One were the emergency department patients, and other was the septic patients after the first 6 hours in the intensive care unit. Coming to the first half of the study, which is still an ongoing study, and I'm going to present some interim results. We just looked at the fluid boluses which were administered in the emergency department. It's not my department, it's a tough study to do because it's not my area. And we try to record every fluid boluses being administered at Flinders Medical Center emergency department. We came up with the simplified pragmatic forms which they can use, and we thought about indication why our ED doctor might give fluids, and we had to improvise and add something like avoid admission to ICU or hospital, or have a big column like others, which big night out they might get some fluids. And then shock, have some kind of definition of shock, that systolic blood pressure less than 90 and probable evidence of organ dysfunction, and they have to tell us if they thought the shock, which kind of shock in their mind was the cause of the shock. And also we had a column of whether they were happy with it or not, whether they thought the fluid bolus for the indication they gave the fluid bolus was effective or not. We also recorded the routinely measured observations, which are normally measured before the fluid bolus, 10 minutes after, an hour after, and 2 hours after the fluid bolus. Coming straight to the results. Remember, these are interim analysis. I've got data for 270 fluid boluses. The average age was 56, 60% were male, and shock, which is where all the research has been for last many years about the effect of fluid boluses, was only present in a quarter of those patients, around 27%. Septic shock being most common, followed by cardiac shock. So fluid bolus is given beyond shock. It's given for, I don't know, we'll think of the indication why it is given, but definitely it's not only the shock patients, where all the research comes from. At Flinders Medical Center, at the emergency department, 0.9% saline was the most common fluid used. A typical fluid bolus was around 750 mils, the median value. Why was it given? Despite shock being a quarter of those patients, 70% thought the rationale for giving fluid bolus was of low blood pressure. Pretty healthy numbers for other indications also. Heart rate, clinically hypovolemic, avoiding admission to hospital and ICU scored well. Others had nausea, headache, whatever. There are a lot of others in this area. And EDs are pretty happy bunch of doctors. They were pretty happy with more than 50% thought that the fluid bolus worked. It might have worked symptomatically, and let's look at the physiological numbers. So, these fluid boluses, before, and these are results 10 minutes after, MAP increased from 80 to 84. Clinically relevant, maybe. Heart rate dropped from 82 to 78. No change in temperature, no change in respiratory rate. These are 10 minutes later. An hour later though, there was no change in MAP, there was no change in heart rate. You make them hypothermic, and the respiratory rate actually went up. 2 hours later, no change in MAP, no change in heart rate. You make them more hypothermic, and the respiratory rate is still high. But these are all patients, right? We are concerned about shock. What happened with shock patients? So shock, MAP went up from 65 to 68, maybe clinically relevant. Heart rate, no change. Temperature drop, and the respiratory rate goes up. So what I'm telling you is some physiological variables which we thought are clinically important. The patient might be symptomatically much better after all these fluid boluses. I don't know, we didn't measure that. But whatever we measured, we found a very small sense of how effective these things are when you actually measure each of the physiological measure individually when you gave a fluid bolus. What about, sorry, I should go forward here. What about septic patients? So septic patients, remember, we didn't measure the first 6 hours, we measured after the first 6 hours, the area which, this bit of gray zone, when to give fluid bolus, why to give fluid bolus. This was funded by Intensive Care Foundation grant a couple of years back. And this was done in ICU, so we had the liberty of using a much more detailed rationale of giving fluid boluses, and we measured everything basically, from physiological measures to biochemistry to blood markers to the lung functions. We measured everything before and after the fluid boluses. I just want to say that these patients were quite sick patients. Their Apache 3 was 80, and the lactate, baseline lactate 4.2. I think the ARISE was around the same number, around 4. So during the study period, after the first 6 hours, 94% of these patients got a fluid bolus. Around 3 fluid bolus per patient they got after the initial 6 hours. Surprise, surprise, the most common fluid in the ICU was 4% albumin, not saline. And day 1, 90% of them got fluid bolus. Day 2, 50% of them got fluid bolus. Day 3, 16% of them got fluid boluses. And they contributed to half to 1/3 of their daily fluid balance. Why were they given? Low blood pressure, still the number 1 cause, increasing vasopressor dose, and there were other causes, low filling pressure. Overall, we have more not so happy people in ICU. We are a bit more sad. We think the fluid bolus didn't work most of the times, around 30%. Maybe filling pressure is helpful. Clinical signs, which is actually difficult to measure from a physiological point of view, scored very well because it's difficult to measure. But this is what happens. This is what happened with the exact numbers. Mean arterial pressure went up from 71 to 73, clinically relevant. Maybe. But then look at the NORAD requirement. It also went up in the same time, an hour later. Maybe, sorry, what happened there? Maybe that's the effect of NORAD. The heart rate, no change. Temperature dropped. CVP, you fill them up, CVP goes up. One of the things which led to other studies was a drop in PO2 5:2 ratio exactly an hour later. So this was objectively measured just before the fluid bolus, an hour later after the fluid bolus is finished, the PO2 5:2 dropped. There was no change in urine output. How many times you have been drinking for a low urine output can you give a fluid bolus? There was no objective change in the urine output. Hemoglobin, you make the hemodiluted, and there was no markers of no change in the markers of cardiac output. There was no change in venous gas saturation lactate. All this cumulative fluid balance, much of it came from the fluid boluses, had all the wrong signals. These have been shown before in previous studies. Negative association with PF ratio, lung injury score, positive association, and increasing SOFA score, a positive association. Not only this, it had some changes on acid-base status and electrolytes, and these are again an hour later, not 24 hours later. Immediately after a fluid bolus, an hour after a fluid bolus, the calcium level drops, the chloride goes up. I'll leave the importance of the chloride and calcium in the pathogenesis of lung injury for Professor Bosen's talk, but more and more data is there that why chloride might be important and why intracellular calcium might be a central event in development of lung injury. To conclude, my fluid bolus is still my pillar of strength. I'm not feeling that strong though. In ED, most of the fluid boluses are used in patients without shock and have minimal physiological benefit. Even in shocked patient, the physiological response is minimal at 1 hour. In ICU, fluid boluses in septic patient after the initial resuscitation have limited success and actually may even be harmful. And they lead to an early electrolyte imbalance. With this, I'd like to thank all the members who have helped me with this study, and most importantly, I'd like to thank the ED and ICU nurses at Flinders Medical Center. Without you, this study would not be possible, and the funding source with the Intensive Care Foundation and NHMRC. Thank you.